Morning, everyone. Thank you for being here bright and early on Wednesday. Let's hope we are going to have a more active meeting than last time so that we can speak up. So I'm going to call the meeting to order. And Jessica, if we want to do a roll call. Do we have to do that? Because we don't have to do that because you can see everybody.
We still have to do it for the record.
Okay.
All right, Ms. Pulowski.
Here.
Dr. Bradbury.
Here.
Dr. Lazarchev.
I'm here.
Ms. Laredo.
Here.
Dr. Payton.
Here.
Ms. Sperber.
Here.
Ms. Schafelt.
Here.
Dr. Sullivan.
Here.
And Dr. Warner is absent today. We have a quorum.
I like that. Okay, on to agenda item number 2, my remarks and comments. So I first would like to go back and again thank Stuart for his time on the MDC. It is much appreciated. As we know, Stuart Ekman moved out of the state, and so he is no longer on the MDC. And then we also, Dr. Meg Warner is also, she has accepted a new position and out of state. And so she is no longer going to be able to attend the MDC meetings. She wanted to thank everyone, and she is going to miss everybody. But I also want to thank her because she has been a tremendous value for this committee, and she is going to be missed greatly. So thank you, Dr. Warner. We're going to miss you, and I'm sorry that you could not be here today, but congratulations on your new position. I want to just briefly go over the VMB meeting that in my report that I presented in January, some of the things that they're going to be discussing at the VMB meeting tomorrow. So I reported, as we all recommended, that the withdrawing proposal of the duties of the supervising veterinarian, they will be reporting, or they will be voting on that. They also are going to be voting on the RVT foreign graduate program. So that's going to be going before the board. So hopefully that will go through with the VMB as well, as we all reviewed that. The RVT fees, the biggest question for them was the veterinary controlled substance permit. And I believe that Jessica has gone back and with the staff created some alternative suggestions for them. So that will be presented to the board, but with some increased veterinary controlled substance permit fees, as well as the recommendations that we submitted to them. So it would be reducing it would be really hitting all areas, not just the veterinarian and the premises permit holders. So because there were questions on that. Why were we not getting everybody? Why wasn't everybody not being affected?
Christy, would you mind if I just clarify real quick? So real quickly, because the mini materials, the revised materials won't be posted until COB today. So more so for the MDC members and the public members who haven't seen the revised memo yet. What it's doing is, as the MDC recalls from the last recommendations, they recommended option B, which increased the premises registration fees the most, but also increased the veterinarian fees for the initial application and renewals slightly. So when reviewing those recommendations and really looking at all of the comments that we've received over the last several months regarding the fee increases, one of the common concerns was regarding the VACSP and that population. They didn't have a fee increase at the time that everybody else had a fee increase. And that was because they were already at their statutory cap. There were concerns raised about the program itself not being able to support itself because of the additional workload that's created because of all the convictions that we have to investigate, because convictions tend to follow that population. And so based on that, I worked on the numbers quite a bit, and I ran them through budgets and the subcommittee, which is Dr. Sullivan and Christie. And we were able to come up with an alternative that does not increase the fees for veterinarians again at all. It'll still increase the same amount for the premises registrations, but for the VACSPs, what we did is we created an initial permit fee. Just like the RVTs and veterinarians, you have an initial application fee, an initial license fee, and then you have a renewal fee. For the VACSPs, they didn't have an initial permit fee. And so it adds that fee, and then it also increases the renewal rate from $50 to $100. So we felt this was it more proportionally disperses the need for the revenue in the increase in the fees, and it allows us not to increase the fees on veterinarians again. So
Thank you. We then went to the subject of telemedicine, which we all know is is really just a controversial topic. And so this conversation did not go as well as we would have liked it to go. And the Veterinary Medical Board is not as satisfied as they would like from the MDC's recommendations. So we made the recommendation to the board that to continue or to keep the condition-specific VCPR, and that is going to be reviewed by the board. However, the board has opted to have its own task force to review access. And so they will be meeting. The MDC is not involved in this. This is their own task force. And so that is something that the MDC will not be involved in. And so we were given authority to further define telemedicine, telehealth, teletriage, and teleconsultation. So we did have the subcommittee go ahead and further define those terms, which we will be reviewing today, as you can see on the agenda. And I just want to say that the MDC, I appreciate everything that we all do on this committee, even though sometimes it is not appreciated by others. It is hard work. I know that during the pandemic, all of you have had an increase in this profession in the veterinary world, and that we've been seeing a lot more pets, and nobody can explain it. Nobody knows why. Nobody knows if it will end. We all know that there is a shortage of veterinarians. Again, nobody knows why. We don't understand it. And you are all working exceptionally hard, but yet you take the time out because you feel a duty to consumers and pets to protect them. And you take time to research and do this and work on this committee. I appreciate it. It is appreciated, and I cannot thank you enough. So I want to make sure that that is stated for the record, and that I trust in all of the work that you guys all do. And I know it's long and hard hours. So with that being said, it also came up that we are going to, I think that that's when the VCPR issues came back around as well. So we're going to be addressing those as well today. And then they had interviews. So I would like to welcome our newest member, Maria Salazar Sperber, which I've met her, but I would like her, if we can, to introduce herself so that you guys can all get to know her.
Hi, good morning. I'm Maria Sperber. I am really grateful to be here. Thank you so much for the opportunity. Just by way of background, I currently work for the California Hospital Association as a legislative advocate. I'm also a licensed attorney in the state of California. I served on the State Board of Optometry for 4 years and had the pleasure of working with Jessica there. So thank you very much for reaching out when there was an opening on this panel. I'm very happy to be here and I look forward to meeting and working with all of you.
Thank you so much for taking time to introduce yourself. I appreciate it because we don't all get the opportunity to see the veterinary medical board meetings and see the interviews. So it's nice to be able to actually see you and get to meet you. Okay. So do we need to go to public comment on anything that I just mentioned? Thank you, moderator.
This is the moderator. We have opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type, I would like to make a comment into the text field and submit that to all panelists. We will now pause for a brief moment to allow members of the public time to submit those requests. Seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Okay, thank you. So we can move on to agenda item number 3, public comment on items not on the agenda. Back to you.
Back to me. We again have opened the Q&A panel. If you'd like to make a comment on items that are not on today's agenda, please click on the Q&A icon on your screen. Type, I would like to make a comment into that text field and submit that to all panelists. And again, seeing now, would you like me to close the panel?
Yes, please.
It is closed.
Okay, quickly moving on to agenda item number 4, to review and approval of January 27th, 2021 committee meeting minutes. Anybody have any questions or comments or corrections? Anybody? Here we go again, crickets. You guys just crack me up.
I move to approve.
Thank you, Dr. Sullivan.
Second that.
Thank you, Dr. Lazarshev. Okay, so we have a motion to approve and a second. Any discussion? Okay, we can open it up for public comment.
Again, this is the moderator. If you'd like to make a public comment on the meeting minutes, please click on the Q&A icon on your screen. Type, I would like to make a comment into that text field and submit that to all panelists. And seeing none, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. Okay, we can call for a vote.
Ms. Pulowski,
Yes.
Dr. Bradbury,
Abstain.
Dr. Lazarchev,
Yes.
Ms. Laredo,
Yes.
Dr. Payton,
Yes.
Ms. Sperber,
Abstain.
Ms. Sheffield, Ms. Sheffield.
Yes.
Oh, thank you. Dr. Sullivan,
Yes.
thank you. Motion carried.
Okay. Agenda item number 5. So we are going on to CCR Section 2032.1, Article 4, Division 20, Title 16 regarding telemedicine. Dr. Sullivan, would you like to go ahead and start us off?
Okay. I think the memo is very detailed and does explain the origin of the discussion and what has evolved in the subcommittee. I think that we really got started on this when we started trying to answer the Q&As, the questions and answers that came forward, because I think there were 4 of us on the discussion panel, and I think there were 4 different answers for most of the questions, and that made us really start looking at the VCPR and some of the regulations, statutes and regulations. And to really, the crux of it came down to looking at the definition of the practice of veterinary medicine. And it says in Business Professional Code 4826, that specifically to diagnose, you have to have a license to practice veterinary medicine in California. And then when we went to the VCPR definition, to my surprise, to diagnose is part of developing the VCPR. You do not have to have a VCPR before you diagnose. That's the process. That's part of the process. So that then enabled us to take all of the definitions that Christina researched and came up with, and then focus on what our needs are and how we can utilize the definition of, particularly of telehealth, to broaden the scope of it to define what a non-veterinarian can do, and then define what a veterinarian can do in the light of being able to diagnose through telehealth. And then we were able to focus more specifically on what telemedicine is and isn't. And teletriage and teleconsulting, we kind of just refined those definitions as to what our understanding and use is now. So I think staff did a great job on the memo, going into great detail as to the sources of where of our thought process and where we received that information and how we finalized where we're at. And I would only add that, as far as the diagnosing part, I think that we kind of all do that already every day. 10 minutes before we're ready to close and a client calls with a specific problem. They just got home from work and their pet is sick, and we get on the phone with them, and in that process we are making a presumptive diagnosis to decide whether it's something that is urgent, that we need to see them right now, or they need to get to the emergency clinic, or it's something that can wait till tomorrow unless the symptoms get worse. So I think that's a good example of putting it into use and to perspective. Thank you.
That's also how we look at teletriage, though, as well. So in a non-urgent matter. So,
well, teletriage is a life-threatening situation.
Right, but that's how we compared the two.
Yes. Yeah.
Any questions? Because this is a very long memo with a lot of information and a lot of work to go into this.
I guess I just have one question, and for some reason my screen went blank, but I guess it doesn't matter. Can you hear me?
We can still see you and hear you.
Okay. I'm technologically challenged. So we're going to be presenting this tomorrow to have us as the board potentially vote on adjusting the code here and just clarifying these things within it. Is that's the goal, and we think we'll be able to do that tomorrow? Is that
Unfortunately, how it works is that I will present it in my report tomorrow. However, you as a board cannot vote on it until the following meeting. And I don't know if you heard that, but yeah, that's, so when when I present something to you as a board at the board meeting, you cannot take action on it until the following board meeting.
okay? Okay, that's that. So we're just going to discuss it tomorrow. Okay, sounds good. This is great, by the way. This is really is much clearer, and I think for me helps me as a veterinarian. So thank you for your work on that.
And just to add to that, Dr. Bradbury, the reason why the board doesn't vote on it tomorrow is because it didn't really give them a lot of chance to review and digest all the information that you guys are considering. And so that's why we like to give them a brief overview of everything that happened within the MDC. But then at the following board meeting, that's when the board will be able to review all of the materials the MDC had, their recommendations, and then make a decision.
Okay, thanks.
Christy?
Yeah, Dr. Sullivan.
I'd also like to comment that this is, I haven't reviewed it completely, but this is in pretty close alignment to AAVSB's definition of telehealth, and also of Ontario's pre-pandemic regulations, in that you know, a diagnosis can be made, but if a prescription or treatment of a specific medication is done, then there needs to be an in-person examination, and that's a lot of what the telemedicine is out there right now is doing and saying. So I think I always felt we were at that level, but I don't think we articulated it as well as we have now. Thanks.
Dr. Payton?
Yeah, I just wanted to thank you and Dr. Sullivan, because it's a lot of work looking through all this, and it's such a confusing topic. So I really appreciate all that you've done, and this memo is really thorough. And I do think that the definitions are very helpful. I agree with Dr. Bradbury. I think that a lot of times we get very confused, and that component of the diagnosis, you know, again, people think that, you know, that, I mean, even myself, like Dr. Sullivan had mentioned, I thought, oh, that was part of ECPR, but that makes sense. And I think your definitions and the way that it was described is much clearer and will be very helpful.
Thank you. I don't see any more hands. Any other comments?
Just well done. It's really very descriptive. I like what you put together here.
Thank you. I feel that we have more information to go to the board with and present to the board, which is what we had asked for. So I think this helps, and I think it helps be able to provide them with the information that they are looking for. And I also think with the information that we've given, it helps the telemedicine discussion along. I believe it gives that piece that they're looking for, but I don't know. Okay.
Can you guys hear me? Can
yes.
you hear me?
Yes.
My computer is still black, so I'm gonna just, you guys keep going. I'm gonna turn off my computer and turn it back on and see if I can get it to come back. If not, I'm going to join from my phone. I may need a new computer, I think, but I just wanted to warn you about what I'm doing. I apologize, but I'll be back on in just a few minutes, okay?
No problem. We're going to go to public comment. So,
Okay, thank you.
okay, thank you. Okay, we can open it up to public comment. Well, I guess first I should ask before I open it up to public comment, moderator, do we, we are looking to be able to go to the board with this. So we would need a motion to be able to take this to the board. Does anybody have that? Would anybody like to
Yeah,
make a motion?
I move we take this to the board.
So it's to
Present
approve
it.
a recommendation.
Yes, yes.
Okay. Now, the wording is down at the bottom, a recommendation to the board to adopt a regulatory proposal to amend. That's what you're saying. Is that the wording, Dr.?
Yeah, that says it much better. I like that.
Thank you, Dr. Lazarchef. So we have a motion to approve a recommendation to the board. Do we have a second? Anybody can second.
I'll second.
Thank
is Maria.
you. Thank you, Maria. I appreciate that. Okay, so we have a motion by Dr. Lazarchef and a second by Maria. I appreciate that. So any more discussion on this? Okay, now we can go ahead and open it up to the public. Thank you, moderator. I apologize.
Not a problem. This is the moderator. We have opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type, I would like to make a comment into the text field and submit that to all panelists. We will now pause for a brief moment to allow public members to submit those requests. Seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. So we can call for a vote, please.
Ms. Pulaski,
Yes.
Dr. Bradbury. I see it. Oh, we'll circle back. Dr. Lazarchuk,
Aye.
Ms. Laredo,
Yes.
Dr. Payton,
Yes.
Ms. Berber,
Yes.
Ms. Sheffield,
Yes.
Dr. Sullivan.
Yes.
Okay, and Dr. Bradbury is still unavailable on marker as absent for the vote for right now. And motion carries.
Thank you. Okay. So we can go on to agenda item number 6, the veterinarian client-patient relationship and developing frequently asked questions. So just a little history on this. This has been going on for a little while, but the biggest component of this was that staff is frequently asked questions, and they're usually given situational questions by the profession or even consumers, and staff is unable to actually interpret the law. They're not able to be an attorney and answer the questions that they have been given. So we have been tasked with developing the answers to these frequently asked questions. It also was the questions were also coming up at the board meeting when they were talking about the VCPR. And so we decided that since the VCPR was so closely related with the telemedicine issue, that we needed to have Dr. Sullivan and myself review this, be the subcommittee, which you saw in the last discussion. It was very closely related. And we were going to work together to try to come up with defining these, or defining and clearly answering these questions in a way that we can have them and the staff can present the questions. We can have them online, available for the public, for the profession, and they don't have to try to answer them. So that's what this subcommittee was about. In doing so, I think there are a lot more questions out there, and I think that a lot more questions will come up. So we would like to put these questions before the board, but I also believe it's a work in progress. I think it'll be a continuous work in progress, because I think once these questions go out, more questions will arise. So that is what is before you. And Dr. Sullivan, would you like to add anything more?
No, you covered it all. I would just emphasize it is a work in process, and I think it's a good way to get information out to the licensees and the public, make things a little bit clearer without putting a burden on staff.
So any comment on agenda item 6?
Yeah, I would,
Go ahead.
sorry. I was just going to say, I really like the concept and the questions, but as I read over it, you know, an answer to one question did cause me to have another question on another part and those kind of things. So I don't know if we want specifics of that, or I kind of understand you guys already know that, but.
I think the questions should be submitted. And so that's what I think we need to do, is we need to just submit the questions to us so that we can, because they're not things that we can easily answer. We need to be able to write them down. And you would not believe how we go about answering them. It's between me and Dr. Sullivan and Tara. Poor Jessica, I feel for her. It's a debate, and if we have trouble interpreting them and we go through them and we have to sit there and interpret this, we have to make sure that we're addressing every aspect of the Veterinary Medicine Practice Act. And so just to make sure that we're giving the correct answer. So I believe it's important to submit the questions so that we're not just answering it verbally, that we're making it a written answer, and we're going to make a list.
Yes, but if she has some concerns about the questions that we've answered, we need to address those today.
Yes, yes. I'm sorry if I misunderstood
Yeah,
that.
no, that's fine. My biggest, I guess, the answer, which they make sense on their own, but the answer about the veterinarian working at emergency practice and then taking those records and prescribing from their regular practice, that part says the VCPR follows the veterinarian, which I do understand, and not the premise. However, in the other questions, we can have a doctor, you know, from the same practice based on Dr. A's VCPR prescribed medication. And that makes me think that the VCPR is premise specific. So I guess I had never thought about the emergency veterinarian thing. So they all made sense on their own. But then when I tried to interpret the answer to that question, it muddied the waters in my head. I guess that's just my comment for now.
I think the bottom line there is that where are the medical records? So if the veterinarian who worked at the emergency clinic and then is back at a different practice, if that person has the medical records with her or has access to them electronically, then I think that's where we made our decision, is that you know, she can continue with prescribing medication. Where it really gets sticky is if there's an associate in that second practice, if that person has access to the records, if the emergency clinic and the new everyday clinic has a link, a business link where the medical records are accessible, then that person can refill a prescription. But if the medical records aren't on those premises, then they can't. And Tara might correct me if I'm wrong on that one, but I think that's where we were going.
That is exactly how we stated it when we talked about it. Because I believe we discussed that when we went through this.
So I have a
Yeah, can we go to Dr. Lazarsheff first, Dr. Bradbury, because he waited?
Well, mine was kind of the same thing. I had a few other questions that arose as I read through this, and I'll, send them to you guys later on. This is a good discussion.
Do you have any questions relating or concerns relating to the questions we wrote?
No, just new scenarios that
Okay,
potentially could
good.
pop up.
We'll take new scenario. Well, I mean, gladly, right? We'll be so happy to accept
Gladly.
new scenarios.
Okay.
Okay, Dr. Bradbury, thank you.
So I like that we have these questions and answers too. So just to say that that's, I think, going to be very helpful. So I just want to make sure I'm clear then, and the medical records, if you're an associate at another hospital now and an old client contacts you and says, oh, they won't refill it there, but you get the medical records faxed to you, then that would be, you'd still be able to prescribe a medication because you've seen the patient within a year and so on, and now you have the medical records. So I think, yeah, if we keep the questions and answers and focus on that medical records and kind of make that a strong point, that's easy to follow, I think. So as long as that scenario is where you get the records faxed to you and then you can write a prescription, if that jives with what you're saying, I think that it's just keeping the medical records as the key is really clear.
That
Doctor,
is
go ahead.
That is a gray area, because what you are then saying is that now, if you're the veterinarian that established the VCPR and you get a copy of the medical records that you wrote, you have them in possession. That is one thing. But if the client faxes the medical records to another veterinarian in that practice, an associate to the veterinarian that established the VCPR, that is not the intent of the original language. The intent of the original language says it has to be, the medical records have to be on the premises of where the associate is refilling or is okaying the refill. The gray area comes in with electronic records. So there has to be some business affiliation between the two clinics for the associate to access the digital medical records in order to fill that prescription. If it's a totally different business, I'm not sure that would be covered, unless you are the veterinarian that did the VCPR. So Tara might want to jump in on that one.
Yeah.
You can keep going, Dr. Sullivan. I mean, Dr. Bradbury.
Oh, yeah, that was the scenario I was talking about, is if you're the veterinarian and you've gone to another practice and you have I think that yeah, that's going to be hard to put into writing, and that always is the difficult thing, but it isn't clear then. I mean, why is it different if it's an associate at the same affiliated practice, but they've never seen the patient? Why is that different than an associate at another practice that still has the entire medical record that's been now faxed to them? Why is that different? And I'm not saying that's right. I'm just saying why is that different legally?
The difference to me is having a 1 or 2 day medical records faxed to you to refill a prescription, as opposed to having the entire history of that patient's medical records that is owned by the premises, that is owned by the actual the business of
Well, and you don't-
clinic.
Yeah, and you don't even know that it's the complete and accurate medical record if it's being faxed to you. You have no assurance that that is the complete and accurate medical record. So if something's been faxed to you, that's just a fax. It's not, there's no way of assuring that that is the complete and accurate record.
Oh, I have a question because we talk about this in a totally different context with regard to humans. So I want to preface that this question is more in a different area. But one of the things that we're talking about in depth is that, electronic health records would be available, all of the records would be available for human patients. So even if you are in Sacramento and you go to San Diego and you break your leg and you go to the emergency room, presumably, if that emergency room doctor who has zero relationship with you whatsoever can pull up your record immediately in real time, and they can see everything, what you take for medication, any previous injuries, any breaks, whatever, and they can treat you with that knowledge. I'm assuming that your veterinarian, generally speaking, do not have that technological capability.
Correct, unless it's a bigger organization like VCA or Banfield or something like that. So,
Okay. So is this something that the veterinary profession is heading toward?
First of all, I'd like to go back to your example. In your example, when the patient goes to a new clinic for a medical condition, as you're describing, that physician is establishing his own
Yes.
physician-patient relationship. So what would be more accurate would be is if that patient goes to a clinic that's not associated with the primary care physician and asks for a refill on a medication. So that would be the analogy rather than physically going with a medical problem.
That makes sense because no different, no physician I know would refill a prescription without checking back with either the primary care provider or getting the record. That makes sense. I just wanted to be clear that when we're talking, that you don't have necessarily the access to verify that that is in fact the medical record. Back to your example about the fax, someone could just send you 2
Correct.
pages of 12.
Right.
yep, correct.
Yeah. It definitely is not as sophisticated as sophisticated as it is in human medicine. So we're not there yet.
And that's okay. There are pluses and minuses, let me assure
Yes.
you.
So so we do agree that we have some more questions that could be submitted to us, and we do understand that it can create some confusion, but I hope that we've cleared that up and it's a little clearer than mud. I hope.
I would just like to add that if you guys do have additional scenarios, just email them to me and then I can forward them to the subcommittee and to Tara so we can get those answered and bring them back at the next MDC meeting.
Any other comments from the committee? What we'd like, again, is we would like a motion to move these forward to the board so that we can get these moved on to the public and the profession so that staff can at least have this piece of information and make their jobs a little bit easier. Everything that we can do to help board staff make their job easier would be really nice. Don't
I
everybody
will
scream.
make the motion to move these forward to the board as a starting spot for questions.
Thank you, Leah. So we have a motion from Leah. Do I have a second?
I can second.
Thank you, Dr. Payton. So we have a motion from Leah and a second from Dr. Payton. Okay, any further discussion? Okay, we can go ahead and open this up to the public.
This is the moderator. I have opened the Q&A panel for public comment. If you'd like to make a public comment, please click on the Q&A icon on your screen, type "I would like to make a comment" into the text field, and submit that to all panelists. Our first comment comes from Diane Sequoia. Diane, your line is open. You will have 3 minutes.
Hi, thank you. I'd just like to speak to Ms. Maria Sperber's comment about records in human medicine being available to doctors in emergency rooms and not your regular treating physician. Unfortunately, I have found in real life that is not always the case. So I would like to say it's a nice ideal, but on the ground, it really doesn't always hold true. Thank you.
Seeing no additional requests, would you like me to close the panel?
Yes, please. Dr. Bradbury, you had a comment?
Sorry. I do want to second the idea that we're not presenting this as a finished product to the board, but more we want to start this is kind of a starting place, because I think there are going to be more scenarios and comments to clarify, and just I think it'll be taken better by the board if we present it in that way.
Okay, you probably missed that. So in the beginning, we did talk about this will be an ongoing project. It is a work in process. It will constantly be a work in process, and we will be getting more questions, and we will keep reviewing them and working them and presenting them as they come up. So yes, absolutely. Oh, no worries. But yeah, we know there will be these questions will make people think of more questions, and we will continually be working on it, and we understand. So absolutely. Yep.
Moderator, it does look like Ms. Lutz is trying to make a public comment. If we can unmute her microphone and let her make a public comment as well.
It was on telemedicine. Does that matter?
I think we can still go back to the agenda item.
Okay, thanks.
Ms. Lutz, I have unmuted your microphone. You will have 3 minutes.
Okay, thank you. It's actually on both, so it's not just on the telemedicine. And you guys did a fabulous job. So, I mean, I'm not trying to cause trouble, but I do see one little problem, just because I know that, somebody's going to ask me this. And on the issue of diagnosis without a VCPR, I totally understand where you're coming from. The problem I have is that the Business and Professions Code, section 4825.1, defines diagnosis as the act or process of identifying or determining the health status of an animal through examination. So that poses a problem when we are looking at telehealth as saying that a veterinarian can diagnose a condition through electronic communication, when we've got a statute that actually says that you have to do an exam. And I understand that that's, confusing, but I mean, I just think down the road, since you're working so hard on this, that it would be a good idea to understand, to look at that, because that is the official definition of a diagnosis, even though the regulation, which talks about a VCPR, doesn't say that you have to have a VCPR to diagnose. And so the comment would be the same on the frequently asked questions issue, which is, and I can't figure out which one it is now. I just had it in front of me.
It's the one that talks about the fecal.
Yeah, yeah. Can a veterinarian do laboratory tests on an animal patient where no VCPR is established? And I totally understand again where you're coming from, but the laboratory tests are required to establish the VCPR, and diagnosis defines it as a diagnosis based on an exam. So the only other comment I wanted to make is that when I look at this Dr. A, Dr. B issue, in the same facility, I look at it as standing in the shoes. And I think that that's helped my clients understand when a second doctor in that practice can, actually, prescribe or do whatever they're going to do without a new VCPR. And that's all I have. Thank you so much. I don't know why I was having trouble with my screen, but thanks, Jessica, and thank you all.
Thank you, Ms. Lutz.
And Ms. Lutz, this is the moderator. If you could please lower your hand, that would be helpful. Thank you.
And Dr. Sullivan?
Thank you. That was a very sharp observation that I surely missed. I would say that the difference that we may have to utilize is that in the 2032.1 on the VCPR, section 2, it does say have a general or preliminary diagnosis. So a little bit different definition, but that's, I think, what we're going to have to focus on and clarify. But thank you for that, for those comments.
I know that's where we were looking at 2032.1 when we looked at that section, and that's the definition that we used.
Hi, this is Tara. So I think the issue with 2032.1 is going to be on subsection H, the definition for telehealth, which would authorize a California licensed veterinarian to provide telehealth that would include a diagnosis of a condition, but limit further action in the event treatment is required. That would have to be through a VCPR. So I think this is a really important point. I don't want to rush this through. This is really difficult because I think we're trying to thread the needle between access to care, how to better utilize teleservices, where to draw the line. And I think this point about diagnosis requiring an exam under the statute, I think that's a complication, and I don't know if you should move this forward to the board without further consideration. Or you could, and we could continue to think about this on the way to the board. This would be presumably brought before them in July. And at that point, we could, I could work with the subcommittee to figure out a better way to address the diagnosis with exam piece with respect to telehealth. I'm just throwing some ideas out there. You could either stop this now and we could try to further discuss diagnosis with exam, or you could continue to move this forward to the board because this is becoming a real critical mass issue, particularly with some shelter stakeholders that want individuals who are in rural settings to have better access to veterinary medicine. And how do we do that? Well, we need better teleservices definitions. So up to you. I think we do need to take a closer look at diagnosis with exam with respect to subsection H on telehealth.
Dr. Bradbury, and then Dr. Sullivan.
So with all of that brought to light, thank you, Bonnie, for catching that, because I think that this would be a big hitch at a board meeting, trying to agree on something like this, and not just at the board meeting, but in the just being contradictory, or not in line with the two different wordings. I guess I would prefer that we wait to present it. I think if we wait, we have to again push forward the date for the emergency declaration to the July meeting. I guess the DCA director would have to do that if I'm correct, because it was waiting on this meeting to determine kind of next steps, was my understanding of the telehealth situation. But I would be in favor of maybe updating the board that this is where we went, but we noticed this discrepancy, and we're still working on it, so that it's clearer for the future. But that would be my recommendation.
Dr. Sullivan?
Yes, I agree with that. I think with Bonnie bringing this forward, and I really appreciate it. I think it's doable. I think in one case you're talking about a definitive diagnosis, and the other you're talking about a presumptive diagnosis. But we need to make that clear. And I think that as an MDC, I think I feel uncomfortable for the subcommittee making a decision and sending it to the board. I think it should be coming from the MDC. So I would support a hold on this, or tabling this motion till the next meeting. And that's my motion.
We just need to withdraw the motion, and I think because go ahead, Jessica.
Sorry, I just wanted to clarify for Dr. Bradbury, this is separate from the DCA waivers that the DCA director has ordered. That was already tackled in the January meeting by the MDC, where they decided to keep the condition-specific language. But in addition to that, though, to create these definitions. So tomorrow at the board meeting, the board will still hear the recommendation to not do anything with the condition-specific language, and then decide on what to do with the waivers. And then separate from that, that's where these telehealth definitions come into play. So they're related but separate.
You're a month behind. I mean, you're like 3 months behind. So you're on mute. You're on mute. Dr. Bradbury, you're on mute.
Well, then I was like, sorry, I'm talking over you, but I wasn't, so that's good. Yeah, no, I understand that they're separate, but I felt like they were somewhat connected in that I felt like they were, that whole motion and the DCA and what they're deciding to do was somewhat waiting on because I was looking at the next date for them to make a decision, and it was after our board meeting. So I understand that they're separate. Thank you for making sure I understood that. But no, I think that this in and of itself deserves just a little bit more clarity before we bring it to the board. But that would, again, my 2 cents.
Yeah, I agree that it needs to wait, but it won't, unfortunately. It's so hard because what I present to the board tomorrow is completely different than what you're voting on. And so it's very difficult that I know that we've come so far and than what you guys are talking about tomorrow. It's very difficult to present when you guys are going to be talking about something that's old. It's almost old. It's kind of dated, but that's the way it works. And so it's a very difficult situation. But I agree and with Dr. Sullivan, and I think that we do need to go back and I just think we need to tweak a few things. I don't think it will be a difficult fix. And thank you, Bonnie, but I think that we need to fix this. And I don't think that it will be a difficult thing. I think that because we did enough research, we went through this so thoroughly, and we vetted everything else. I think we need to go back and take a step back, and we can go back and tweak this just slightly and make it fix what we need to fix.
So then to clarify, it sounds like we're actually looking at both the frequently asked questions and the telehealth definitions. Is that correct? Looking at holding off until we can look at both of them? Is that accurate?
Sorry, I needed to clean my glasses so I could see what I was doing. I don't know how they got so dirty.
I think the questions and answers can go forward.
Yeah, I believe
Okay.
that except for the last question in the Q&As, because the FAQs.
Okay, so the reason I'm asking is because we already have that motion that carried, and so and Tara can correct me if I'm wrong, since we already have a motion that carried, we would have to have a motion to reconsider that motion and then have another motion to withdraw.
That's what I was saying. Yeah, that's what I was saying. We have to go back and correct that motion. So on the FAQs, Dr. Sullivan, that last question talks about diagnosis. So that question could not move forward. So we could move it forward.
And right now we have a motion and a second for the FAQs. So
And
you
that
could have,
that would need to be amended to accept all but the final question. And then
I don't think we need to leave out the final question, which is number 5, laboratory tests. Is this the one we're talking about? Because number 5 does not authorize a diagnosis, which is the issue that we need to flesh out a little bit more for the VCPR telehealth. This is just, can a veterinarian do laboratory tests? You can do tests without having a formal diagnosis. I mean, this is just, can you do tests without a VCPR? Yes, you can, because the tests are part of the diagnosis leading up to treatment, which, you know, when we get to treatment and question mark on diagnosis, you need the VCPR. So I think 5 is fine.
I know that's just where we came up with this diagnosis part. So I was in my head. Okay.
so if we do want to move the FAQs forward, then we do have the motion in a second. So I suggest we resolve that and then do another motion to reconsider the motion for agenda item 5.
Okay, so we've already had public comment. We just need to call for a vote.
All right, Ms. Pulowski,
Yes.
Dr. Bradbury,
Yes.
Dr. Lazarchuk,
Yes.
Ms. Laredo,
Yes.
Dr. Payton,
Yes.
Ms. Sperber,
Yes.
Ms. Sheffield,
Yes.
Dr. Sullivan.
Yes.
All right, motion carries.
Okay, so then we're going to go back to agenda item number 5, and I apologize to the public, but we're going to go back to agenda item number 5, and we are going to.
I move that we reconsider this motion.
That's what we're going to do. Thank you, Dr. Sullivan. Do we have a second? Thank you, Dr. Lazarchuk. So we have a motion from Dr. Sullivan and a second from Dr. Lazarchuk. Do we need any public comment on this, please, moderator?
This is the moderator. We have opened the Q&A panel. If you'd like to make any comments, please click on the Q&A icon on your screen. Type, I would like to make a comment into the text field and submit that to all panelists. Seeing none, would you like me to close the panel?
Yes, please.
It is closed.
This is Tara. It looks like Bonnie Lutz has her hand raised again. I'm not sure if she's having trouble typing in with questions or comments. We may want to check in with her about her raised hand.
Yeah, this is the moderator. It's been raised the whole time. Miss Lutz, I've unmuted your microphone. Did you have a comment to make on this item?
I'm sorry, no, I'm having trouble with my computer this morning, so I appreciate it, but no, I'm trying to get rid of my raised hand, but it doesn't seem to want to go away. So
No
that's sort
problem.
of my personality. My hand is raised all the time, as you know. So
Not a problem. Thank
we'll
you.
just leave it at that. You can ignore me.
Okay.
That is impossible to do.
Okay, so can we call for a vote on the recall?
Ms. Pulowski,
Yes.
Dr. Bradbury,
Yes.
Dr. Lazarchuk,
Yes.
Ms. Laredo,
Yes.
Dr. Payton,
Yes.
Ms. Sperber,
Yes.
Ms. Chaffel,
Yes.
Dr. Sullivan,
Yes.
motion carries.
I'd like to make a quick comment on the definition of diagnosis. We are, you know, we may be opening up a real can of worms there with large animal practices. Anyways, I'll leave it at that.
Well, Dr. Sullivan, I remember discussing this, so I do know that we talked about it. I know that we talked about it because I have it in my notes, but I'll go back to it and review my notes. So, yeah, I know we talked about it. Okay, so let's go on to agenda item number 7. So, which is the veterinary premises inspection checklist. And I'm going to give this over to Miss Laredo. It's up to you.
Okay, well, with that, first I want to thank Dr. Warner for all of her help with this. She will be missed, not only by the committee, but by the subcommittee. And then huge thank you to Jessica and the staff. We have met several times to discuss this. We've reviewed the inspection process and the checklist. And Jessica was kind enough to set up a meeting with the dental board, the Board of Barbering and Cosmetology, and the Board of Pharmacy so that we could touch base and get some ideas from each other. One thing that was very eye-opening is that out of those boards that are also part of DCA, we are the only board who has a percentage mandate. So we have that 20% mandate to inspect, 20% of all of the premises in California, which I think, if I did the math correctly, comes out to about 900 hospital inspections. Clearly, we've never been able to meet that. And it became very apparent that that's just an unrealistic mandate. It's just not feasible. In addition, we were the only board of those 4 that do not have employed inspectors. So we do use contracted licensees to do the inspections. So that was another huge difference. And we did come up with some ideas and some questions. So this is still a work in progress. We did ask for some feedback from our current inspectors. In reviewing the checklist, there are 42 items that are inspected when the inspectors go out to the hospitals. Clearly, that takes some time in addition to the paperwork they have to do. So we talked quite a bit about the app that is possible to streamline that process. There was mention of adding a citation or a fine to go with that citation. And my question was, what type of change would that be? And it looks like the board already has the authority to issue citations, so that would just be a process change. We asked for some feedback from the current inspectors as far as any potential changes to that checklist. Some of the other boards have streamlined the process. They have a shorter checklist, and we do need to, I will come back to you at the next meeting with some more information, but so far it doesn't seem that reducing that checklist would be in the best interest of consumer protection. And I think the app is going to make a lot of progress as far as streamlining the process of paperwork and the time that it takes from beginning to finish with the inspections. And I know Jessica can give more information about that. There might be a fee associated with that. One thing that I did like that the other boards do is when they do, I know when we say fines and citations, everybody panics. it's again to incentivize compliance. It's not to penalize anybody. And the some of the boards give their inspectors discretion to only issue fines for the more egregious issues, and not just to issue citations and fines. So again, I think there is some progress that can be made. We still need some more feedback, a little bit more work, but I think the biggest issue here is that our mandate is just not realistic. And in comparison to other boards within DCA, we have this very huge mandate that not even other boards have. So with that, I don't know, Jessica, did I leave anything out?
I think the only other thing I would add is the information about what other states are doing as well. We provided that information in there, and there's a lot. Most states don't even actually inspect facilities. There's a lot that don't register facilities, and so they feel like they don't have the authority to go in and inspect the facilities. And so there were a couple that had responded that they do have a mandate, but they have a much lower volume than California. So that's the only thing I wanted to add.
Any questions?
I appreciate you doing all of this. The information was great, and I was interested to see what other states or other inspections happen and their numbers. And I always thought that the 20% was high, and I knew it was never realistic. So it was nice to see it written down. Dr. Bradbury?
I'm like Bonnie Lutz. I always have my hand up. Um, this is awesome, and I think this is the trying to think how we do this is going to be really important for consumer protection in the future and just for the program. Why is it that we contract them out and don't have them as employees like these other boards?
So that's one thing that we're evaluating as part of this process. It's my understanding that when the inspection program was created and we had these contracts with the veterinarians, and I think we have one RVT who's a contracted inspector too. The whole thought is that they are the ones who are able to actually review medical records, and that's why we would need licensees to do it. However, there's other alternatives. Especially now with the ability for our inspectors to upload take a picture of the medical records and upload them into a secure server. That would allow us to provide those medical records to the subject matter expert where there would be licensees. So this is something that we are exploring as part of the subcommittee, or alternatives to contracting with veterinarians. There's other things to consider. If we do not contract with veterinarians, then that means we have to employ state employees to perform these, similar to the other programs. So that might be more cost to the board because we have to pay for a full-time employee plus all their benefits that come along with that. But the plus side is that we have a lot more control over what's occurring, and they would be full-time devoted to these inspections. Another thing we have to consider is that there's a general business and professions code, I believe, or a government code that states that we have to use state employees whenever possible. And so if otherwise we would have to go out to bid for a professional to do these services. But the reason why we're able to do subject matter experts without the whole bidding process is because we make the argument that's very unique, and it has to be licensees who perform the service. But like I said, we're really evaluating the entire process and the best options for the board moving forward.
Thanks. And sorry, I just had one more follow-up question.
Nope, you're fine.
The citations. So as I understand it, there would be they would see some, something that would be citable, and then issue it at the time of the inspection so that it kind of closes a step and reduces the time and improves efficiency. Is that the idea there?
So it really depends. It's going to be on a case by case basis. Most of the time, though, we would allow 30 days for them to comply. There's some things that they can comply with much quicker than others. Sometimes if they have to do maintenance on equipment, or if they have to order some supplies, or they have to do other things that might take them longer to comply. But generally, we give them 30 days to comply. When we issue citations, it would be more so if they weren't able to correct the issue within 30 days. Or if it was a repeat offense, then we've already told them before they have to correct it, and they didn't, then we would issue the citation. So it's really on a case by case basis. But like we've said in the past, the inspection program primarily is used for educational purposes. It's just being able to, after that time period, to provide to get them into compliance. If they're still not in compliance, then we would issue that citation with the fine.
I did want to add three things. One, Dr. Bradbury, keep your hand up if we get to see that beautiful background. I feel like I'm outside for a change staring at this computer.
Totally agree.
Keep that hand up if you need to. One thing I did leave out is we had also discussed the possibility of doing the self-inspection checklist for hospitals that are renewing their premises permit, which might reduce the load a little bit. And then if they are inspected and something is wrong, then we can cite them for fraud and deception because they said that that was great. Another thing is I really did like the idea of having our licensees going out as inspectors. I've gone pre-COVID, I went on I guess you would call it a ride along with our hospital inspector. And there are certain things that we've all been in an inspection, the inspector shows up, everybody flees. There are certain things that only the licensees would pick up on, certain little red flags. And additionally, we know that we have our complaint-driven inspections, but when we have the random inspections, there are some things that only a licensee would notice that I've heard inspectors say that they've walked into hospitals that shouldn't even be operating, but we know that the process from start to finish takes so long. And that's something that I feel might be missed by non-licensees doing the inspections. So it was also pointed out to me that I think 2 executive officers ago, they would present a presentation of some of the horrible things that would be found on hospital inspections, so that it would be an incentive to everybody to keep in compliance, because it's not always the tiny things, it's sometimes the more egregious things. And I think that it's some people are very visual, so seeing examples of what not to do might be helpful. But this is definitely a work in progress, but a huge thanks to Jessica and the staff for setting all of this up. It was so eye-opening to see what other boards are doing and to just realize that we have higher expectations on our board than other boards within DCA. So we just don't have the resources to do what the mandate wants us to do. That's all.
So,
And just to add, we do still do those presentations as well. So.
I have a question regarding the program, the mobile app, and I know you and I had talked about it. What is there going to be a requirement for you to be able to get the software implementations? Or are they going to, is that even a possibility? Or are they going to make you do a cost study analysis in order to show that it's worth it?
No, so we're still in the research stages right now with Dental Board and Barber and Cosmetology and OIS. So we've seen a demo of the mobile app, and I do believe it's going to be extremely beneficial for our inspectors and for the staff. It's going to streamline a lot of the processes and make it a lot more automatic. And so I think it's definitely worth it. I provided an estimate cost breakdown in the memo provided, and that's going to be divided up by the number of users. So Dental Board has the most number of users. We're the second most. I'm sorry, not Dental Board. Barber Cosmo has the most users. We're the second most users, and then Dental Board only has 2 users for that. And so that's how we would pay for it. I've been looking at the budget very closely, and I do believe that we would be able to absorb these costs with all of the other cost savings that we've implemented over the last couple years. So I think that right now it's something that we want to proceed with exploring. We don't have set costs yet, and we won't have that until later on in the process. But we're hoping to be able to roll it out by the summer of next year.
You. Yeah, the complaint audit committee is going to save you money, right? So you can Well, thank you. I appreciate this because I think it was very informative. I think it helps and it gives us more information. So um, I think there was nothing more that we needed to move forward on this, correct? Any more questions? Thank you, Jennifer. And I appreciate you doing this. We'll get you help again soon. So, and we can open this up to the public for any questions.
This is the moderator. We have opened the public comment Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen, type I would like to make a comment into the text field, and submit that to all panelists. Our first comment comes from Grant Miller. Grant, your line is open and you will have 3 minutes.
Good morning, everyone. Good to see everybody. This is a fairly light comment, but I just wanted to give a little bit of historical perspective on the inspection program. There is a 20% mandate for the board to meet these inspections, but that mandate was self-imposed by your own board. So in the previous administration, prior to Jessica being there, the executive officer, they were having problems funding the program, and the law had said that you had a 20% goal, but that, you know, when resources ran out, then that was it. It was over. And so Patty, the inspection folks would only end up being able to inspect a certain number of premises because the, you know, whatever funding was available would just run out. So in the last sunset review, the VMB changed it to mandate 20%, which then triggered a hard line item budget expenditure for the inspections. So it secured the actual budget funding to allow the 20% to actually happen every year. So that, you know, stringent high mark was actually self-imposed by your own doing. So anyway, just wanted to say hi. Hope everyone's doing well. Thank you.
What can I say? We're overachievers.
Christy, I'd like to just add to that, and thank you, Dr. Miller. So I do know that it was part of the board's last sunset, and I think that there might have been a little misinformation or misstatement of how funding works. So you can put in a statute, a 20% mandate, and that might help you secure a BCP, which is a budget change proposal for additional staff, but it in no way will give you additional funding. As you all know, we are special funded. That funding only comes from licensing fees. And so in order to actually fund those positions needed, you would have to increase the fees in order to meet the mandate. So that's another option, that if the board feels that we want to keep the 20% as a mandate, then you may want to seriously consider raising the premises registration fees even more to meet that mandate. Because putting in that mandate doesn't secure any additional funding for the board.
Thank you.
I
Any
have
other?
no additional comments. Would you like me to close the panel?
No, yes, please. Thank you.
It is closed.
Okay. Any other comments? I think we are good to move on to agenda item number 8. Update from the Complaint Process Audit Subcommittee, Dr. Lazarshev.
Hi. Yeah, this has been going quite well, especially with the newer setup. You know, COVID actually had some benefits, and it gives us more time to look at each of these cases and review them. Rob sends the cases. We go through looking for you know, biased language. This time they added some stuff, giving us timelines of how long each case was with the various aspects of the complaint process. You know, how much was in-house, how much time was at the DA, and they also gave us some costs associated with that, which can be kind of staggering. It really gives you an idea of how much the board is having to pay when this stuff gets to the AG and lingers around in the legal system for a while. think you can see some of the recommendations we had were the particularly that of the long cycle times at the AG's office. Some of the inspection times too, or the inspection units. I don't know what can be done about that. Again, this is all pretty concise. You can go through and read everything. Excuse me for just a minute.
This would be the downside of having to do work at work.
The kids, as soon as you get on the phone, there's not questions for you. Sorry about that. Let's see. Again, Rob's going to give us on the next batch. Again, he's going to give us time and costs associated with each part of the complaint process, and maybe help us better streamline some of those. Some of the current recommendations coming with the staff is before it even goes to the DA. They're saying, you know, we would be willing to settle for this, and that allows for much shorter periods of time when things have to go there and incur those high costs. Were there any questions about anything that we had here?
Not
We did
seeing
get
hands.
And
Anybody?
I can chime in too. I think that,
Yeah,
that Dr. Laz was really hitting on the cost, and I think that was really surprising, which we're going to continue to do. I think for the next complaint audit subcommittee is show those costs, because if you looked at the memo, they are for 8 cases that we presented, and it wasn't just cases that involved experts. It was just a variety of cases. We had citations, we had petitions to revoke, just so that the committee or the sub audit committee, sorry, complaint audit subcommittee, I always mess up the sub, could really get a feel for everything enforcement and really what's going on, rather than just cases that were limited to experts. They found the obvious cases that we, I think, rectified a while ago, where we have multiple experts, because that's obviously a problem. They noticed on some of these cases that when you have 2 experts, as expected, you're going to have them with sometimes conflicting opinions or contradictory opinions. They also noticed, I think, that in one particular case, that the expert was not as resolved in their opinion, which caused a weakness in the case. And that's something that we tried to figure out prior to transmitting to the AG's office, because obviously the AG's office is not cheap. And then some of the other costs on there are just obviously D of I. We're really utilizing them a lot less. We're using the inspections program as much as possible. And then you can see just not utilizing D of I, using a single expert, knowing if a case should go to the AG's office. I mean, you're talking, you know, just with these sample cases, just right around $50,000. And then, of course, in some of the cases, I'm sure many of you are aware that cost recovery is something that we can get, you know, and we try to get whenever it's possible. But there are cases where we just can't get cost recovery. When it's a petition to revoke, the cost of hearing, a default, or a revocation or a surrender, likely we're not going to get those costs back if they're leaving the profession entirely. So, I mean, it's one thing to order the cost, but it's another thing to actually get those costs back. And I think, you know, some stakeholders might believe that, you know, enforcement is just a 1-to-1 ratio of cost, where you just, you know, you have those expenses and you order cost recovery and it covers that. And it's nowhere near that at all. And then you don't even consider the cases that go to hearing. The cost of hearing is kind of out the door. You're not going to get that back. And if it does go to an ALJ, in most cases, when they are considering the Zuckerman precedential decision, they're going to lower the cost of that, the cost recovery anyway, just based on the ability to pay and the code of regulations that they apply to that cost recovery. So it's really an uphill battle to try and get all cost recovery, but we're going to try and do it in every case that we can, in concert with our DAG liaison. But I think that was really something important that we have the subcommittee looking at as well. So we'll continue to give them a new batch of cases. I think it'll be a wide range of cases, and then give them those timeframes and those costs, because it's really important, obviously, with the board's fund condition, to ensure that we're trying to get the maximum cost recovery on these cases.
Hey, Rob, on the few cases where we found, you know, minor prejudicial language or something like that, you went back to those expert witnesses, and I understand we had some positive feedback from them.
Yeah, it's actually, I think it's gone really well. Just I've contacted, I think the past 3 times the experts who were involved in these cases, and a lot of times I think as expected, these cases are much older. We've changed the process since then to really have them look at just the standard of care and how that applies and provide an opinion on that. Whereas before they got a little bit more in the legal aspect of things, and they've taken the feedback really well. They understand it, and I think they appreciate getting that feedback because a lot of them say that they just feel totally alone. I know that one of the experts felt like they had really messed up a case when it went to hearing and almost didn't want to be an expert again because they hadn't gotten that feedback. And I think it's important that if we have somebody who's going to be a good expert, that we try to help them as much as possible, whether it's through from the staff feedback, from the subcommittee feedback, and from the DAG's feedback. If it does go to hearing. And I think it's really, really important because we have a lot of great experts and we really want to keep them. So I think it was all great feedback, and I'll continue to call them and give them that feedback. Like I said, none of them have bitten my head off. They've all been really receptive. So I think it's been really productive.
So I have a question regarding, a couple questions actually. So 2019, I think is when you mentioned that you've started the process. This is when the review process started. So when would you say, where are we in the correction part of it, where we're really going to start noticing a difference in the current cases?
I mean, I think we started the correction process a while ago in a lot of these areas. So we're dealing with a lot of these cases. They're much older cases that obviously they have to go through, the legal process at the AG's office. So a lot of them are just older cases. So the die has kind of already been cast on those cases. So we're not going to start to see those savings until, the newer cases that we're transmitting, which we have had some of those cases, definitely, but we still have those old cases that had multiple experts. And obviously the goal of enforcement is to work on the oldest cases, and they're still really trying to work on those cases. The cases are extremely, let's just say they're tough. And I know it definitely takes its toll on the staff because they're really trying to pick up the pieces on a lot of these cases where it feels like maybe the prior staff may have touched it a little bit, but didn't follow through. So they're really having to start from scratch and sometimes scratching their head trying to figure out what was done. And they've already had multiple experts, and we're really trying to pick up the pieces and make the most of the case and the investigation in front of us. So we will start to see those, but we are still dealing with cases that are several years old, unfortunately. But we have to obviously investigate every single case.
And I just want to, sorry,
go ahead.
I was just going to add quickly, you can see in the memo, a lot of the concerns that the subcommittee has found. I think the great part of it is that the enforcement team has already taken a lot of steps to mitigate it prior to these issues being found. So it's really, in the memo, it really breaks that up to let you guys know that yes, they are still finding this, but it's primarily because the subcommittee is looking at disciplinary cases that are done and completed, and then no more appeal rights. And so with those, even though they're recently completed, it's going to be in those cases, a lot of them are from 2016, 2017, where a lot of these steps have already been taken. There's already been multiple subject matter experts involved. There's already been D of I involved that maybe shouldn't have been involved. So a lot of these things we're probably still going to see for at least a year or so while we clean out these cases, and then you'll start to see the real fruit of the labor of what the enforcement team has been able to do.
And I think it was also interesting, the subcommittee found that we had a couple of cases in there, and I think they noticed, hey, this is for example, a conviction case. Why did we have an expert involved? And I think that's really great that they were recognizing the things that we have changed as something that needs to be changed. So I think it just reinforces the changes that we've made, which is really great.
And would you say the savings, the cost to the board, I should say, not the savings, but the cost to the board, is that representative of what could go forward if these changes were implemented? That's representative of the cases?
I mean, I can't make a prediction on what the cost savings is going to be. I can only assume that we're doing the best we can to get the most cost recovery and save the most when it comes to investigation, utilize the resources that are at hand. Obviously, we are going to get cases sometimes where we know we'll accept a surrender and that's it. And if the respondent wants to take it to hearing, we understand that's just part of it. That's part of the enforcement process, to where we don't want to simply say, you know what, it's not in the consumer's best interest to have this person practicing, but we want to save money, so let's go ahead and just put them on probation. If it's not appropriate, we're going to take it to hearing because that's appropriate for consumer protection. And obviously, when it goes to hearing, especially when it's a really involved case, and we've had a lot of cases at hearing that are really, I mean, multiple week hearings, and each day is, you're talking thousands and thousands and thousands of dollars. Those costs are not coming back, but it's basically the cost of enforcement, and we have to take it to hearing. So we have had several of those. So, you know, it really depends on what we have in the hopper, I guess. But ultimately on our end in enforcement, we're going to try and save as much as we can.
But the idea of this process is to assure that those cases are the ones that need to go and the other ones are handled the way that appropriately and handled the way that they should be. That's the idea of the process. So.
Absolutely.
Thank you. Dr. Bradbury.
In the part of your discussion where you were talking about the feedback to the expert witnesses, which I think is great. I mean, that's the only way we learn is to know what we're doing and the things we can improve on and the things we're doing well. Are they getting any coaching by the DAG or anybody in terms of how to testify? Like I've been in a court case myself, and it's not the most straightforward, but I know they've gone to the medical board sort of expert witness training. I didn't know if that was also something that included how to actually testify in these hearings. Is there anything like that going on?
Yeah, I mean, the MDC training should cover it. I think it's pretty comprehensive, and I know it's for human medicine, but it obviously applies to our experts as well. And that's really what we based a lot of our revamp of the expert review program on. The other thing is when there is going to be a hearing, it's typical for the DAG to be in contact with the expert, so they're going to have a lot of prep work done there as well. And that's obviously something that's another cost that's going to be associated with our expert costs, and that's totally fine. We want them to be able to testify and to be resolved in their opinions, and be prepared for that. So yeah, and usually after the hearing, we do get the feedback. I mean, our DAGs have been really great when it comes to hearing and giving us the feedback, but they'll tell us, hey, the expert did a great job here, or they'll tell us other opportunities that we might need to address. But for the most part, we're getting a lot of positive feedback from our experts, which I think is really good. And I think it's just a testament to the prep work from the DAG, the MDC training, and hopefully just the clarity on the revamped expert witness program, so that they know, hey, I don't need to wonder about what I should be putting here. I'm just sticking to the standard of care, and that's what I know as a licensee. So I think all around it's getting stronger and stronger.
Regarding the MBC training, they've had ALJs come and provide part of that training, and they also have deputy attorney generals who come and provide that training to really go over testimony, things that work well, things to steer away from, and also report writing. So all of that is covered as part of that training.
Any other discussion, comments, questions? Thank you, Rob. Thank you, Dr. Lazarsheff. Any more discussion before we open it up to the public? Okay, moderator.
My apologies, I lost my box that let me open the panel. This is the moderator. We have opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to all panelists. And seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. Okay, agenda item 9. So normally we will make appointments to a certain subcommittee. However, this one is a little bit different because I feel like you should probably be really interested in this. It's going to take some work. We're looking for volunteers to develop content for continuing education webinars. These are things that could educate people on what the board does, on statutes and regulations. It can provide CE. It's similar. We're looking for something that's similar to the sexual harassment training that we've all done. And so it'll be that type of continuing education that's done online. So I don't know if Jessica wants to explain it more so that they have information before everybody just raises their hand, because I know everybody's going to be so interested in doing this.
Yeah, thank you. So this is really looking at in what ways can we better serve our stakeholders and provide more opportunities of education. And so with that, the first one was our priority, and that's taking the current California state law exam and transitioning it into a more educational webinar and being able to provide it to all licensees, regardless of license type. They can all benefit from this webinar. And so we have already asked Dr. Bradbury and Maria Sperber to work on this course, and they both agreed to do that. So with that, they are using some questions that we are already using for the law exam. They're going to morph that into a training similar to the sexual harassment prevention training that all of us have to take as being affiliated with the state. So we feel that that's going to be a really great opportunity for all of our licensees to learn. And then over time, as laws change, that webinar would be updated. And then another avenue we want to create a webinar for is for inspections. So it would create a webinar based on the top violations, things to make sure that they're doing properly. And then another one is similar to inspections. We want to also do enforcement of overall violations that we're finding in enforcement and ways to avoid enforcement actions. And then just another one related to just board overview in general of what the board does and just our role in consumer protection and then providing services to stakeholders. So those are just the four my goals. And obviously this is going to be very time consuming in just developing the content. Once we have the content though, we can work with Solid and Office of Public Affairs and DCA to create these webinars to post onto our website. And we would be able to offer free continuing education to any participants of the webinars. And then if the MDC or if the board members have any other ideas or stakeholders of other webinars that they would like us to offer, I think that that's a great opportunity. And they would just email me and then we would work together to create that information. So with that, if anyone would like to volunteer for one, please let me know.
I see. I told you, you all would be just like so excited to do this.
I'm happy to help with some of the content. I don't know which specific one yet. Let me think about it. But I'd love to help get the content, and CE is so important. So I'm always happy to help on that aspect.
We appreciate it. Dr. Bradbury?
I just want to make sure we're going to have like actors doing this, right? Not like I don't actually participate.
Yeah, so much like the sexual harassment prevention training, it's pretty automated. There's characters that are doing it. However, I do want to say for the record, Dr. Nunez has offered to be involved in any sound bites or TikTok videos. So I'm sure he'd be happy to do that as well.
She doesn't want to volunteer unless she knows she doesn't have to be in the video. That's a great question.
So if you all just want to think about it and then get back to me and let me know if you're interested later on, or if you have other ideas for webinars, please let me know and then we'll work on those together.
Yeah, because we're all just jumping up and saying, absolutely. So that was a great question though, Dr. Bradbury. I appreciated it. It doesn't surprise me that Dr. Nunez volunteered for that though. Okay. Let's open it up for public comment. And Miss Lutz has again said she needed to make a public comment on the last one, and she didn't get to it because her hand was still raised. So here we have to go back to Miss Lutz. Can we please make sure we get her this time?
Absolutely.
Thank you.
This is the moderator. I've again opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type, I would like to make a comment into the ask field and submit that to all panelists. And while we wait, we will open it back up for Ms. Lutz. Ms. Lutz, your line is open. You will have 3 minutes.
Okay, thank you. First of all, if the volunteers are not limited to board members, I'd be happy to volunteer for webinars. That's just an aside. As far as enforcement, I just wanted to make a comment. I applaud what you're doing. I think it's really important. As far as, a comment that I'd like to make about sending everything over to the Attorney General's office. While here in Denver, and there's a lot of other DAGs that are extremely experienced, when a case goes over to the Attorney General's office, it's given to, whoever's there. And, oftentimes these places are, there's a high turnover. It's given to somebody young who isn't familiar. So when everything is sent over to the Attorney General's office, oftentimes there's this, and we call it in regular law, throw everything up against the wall and see what sticks. So I would get accusations with all kinds of things in the accusation, where if I had an experienced DAG like here in Denver, we'd be able to sort of get it down to what was important and then hopefully settle. So, I do encourage you to continue this process of, working with the Attorney General and having more in-house review before you send it over to the Attorney General's office, so that you save money for my client, you save money for yourselves, because we don't have to go to hearing because my client won't admit to the 6th cause for discipline, but he's willing to admit to 1 through 5. So that's just a comment I'd like to make, and I applaud you for what you're doing. Thanks.
Thank you.
Seeing no additional requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. Okay, and now we can move on to agenda item number 10, which is future agenda items and meeting dates. So, Jessica, do we have, I know we know we're meeting virtually for the rest of the year. We've already established those dates. And then as far as future agenda items, we know we're going to be coming back with the definitions. Oh, we need to go back. I apologize. I did not go back. So I need to go back because we need to revisit telemedicine one more time, because in Dr. Sullivan's motion, he withdrew, or he asked for a reconsideration, but he did not withdraw. So we need to make sure that we get a motion to withdraw the telemedicine motion. So I apologize. I needed to go back to that. So for agenda item number 5.
Do we want to withdraw or to table it?
Because we had the motion on it, I think we have to withdraw the original motion.
Okay.
And so that's why.
I move to withdraw the motion on telemedicine.
Yeah, so we have to withdraw. So I appreciate that. And I apologize that we have to go back. So I have a motion from Dr. Sullivan to withdraw the motion. Do we have a second?
I'll second it.
Thank you, Dr. Bradbury seconded the motion. So now we have to open that to public, or do we have any discussion? I'm sorry. Do we have any discussion for the third time? Okay, now we can open it to public comment.
This is the moderator. We've opened the Q&A panel. If you have any final comments on agenda item number 5, yes, please click on the Q&A icon on your screen, type "I would like to make a comment" into the text field, and submit that to all panelists. Seeing none, Ms. Lutz, I'm going to check in with you one more time. Did you have any comments on this item?
No, but thank you.
Thank you. And with that, would you like me to close the panel?
Yes, please. Thank you.
It is closed.
Okay, can we call for the vote?
Ms. Pulowski,
Yes.
Dr. Bradbury,
Yes.
Dr. Lazarchuk,
Yes.
Ms. Laredo,
Yes.
Dr. Payton,
Yes.
Ms. Ferber,
Yes.
Ms. Phelps,
Yes.
Dr. Sullivan.
Yes.
Motion carries. Thank you.
Okay, I apologize for that little blip. So we now know we will be discussing the telemedicine definitions next time. We will be continuing the VCPR questions, and then what other topics are going to be coming forward? Because I know that we've had other topics that they've wanted us to discuss. So are there going to be anything new? Is there going to be anything new from the board coming forward? Do you think?
Not so far. I have those as carryover items. Obviously, the complaint audit subcommittee is going to continue. The inspections review is going to continue. But this would be an opportunity too if the MDC would like to look at additional items.
Okay. Are there any new topics that anybody wants me to bring forward to the board? I mean, we do have a lot of work. It's not that we don't have anything on our plate. And we have the videos that we're going to be working on that I know that you're all dying to volunteer for.
I just want to say, I think for the webinar, after our discussion today, we probably need one on telemedicine once we get this all done. I think that would be a great topic. Just
Yeah.
putting it out there.
Telemedicine and the VCPR, you think? That probably would be.
No, I do. I actually think they'd be really helpful webinars. So
I agree with you.
Thank you, Dr. Payton, for volunteering to create that in the future.
no problem. It'll be kind of the future because we still need to iron this out first.
That is a great idea, though. I do agree. Okay. Any more discussion on future agenda items and meeting dates? Okay, we can open it up to the public, please.
This is the moderator. We've opened the Q&A panel. If you'd like to make a comment on future meeting items or dates, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to all panelists. And while we wait, I'm going to make one last check-in with Ms. Lutz. Ms. Lutz, do you have anything on this item?
I don't. Thank you very much.
Thank you. And seeing no other requests, would you like me to close the panel?
Yes, please.
It is closed.
And then before we move on to the next item, just a reminder to all of you to start thinking about, we're also doing MDC elections in October for them to take over in January.
Wait for it. Moderator, Dr. Nunez has come to.
I see that. I will open his line. Mr. Nunez, your line is open.
All I wanted to say is that I'm ready for my close-up.
Thank you. We appreciate that. We're ready. We're ready for you. Oh, okay. With that, are we ready for agenda item number 11? I'm pretty sure I am. Anybody ready to move to adjourn? I think we're good.
Yeah, we don't need a motion. We can just
I know.
adjourn.
I said I moved to adjourn.
Oh,
Thank you all. I appreciate it. Thank you, Maria,
Thank
for
you. Bye.
joining us. Have a good one, everyone.